Hello everyone, welcome back to Bright Life Science Uganda, your one-stop center for medical related information. In this video, we are going to talk about rheumatic fever and rheumatic heart disease. You see, cough or upper respiratory tract infection, or what you can call throat infection, is often regarded as a simple infection and easy to manage. But in this video, we are going to see that it can actually turn out to be very dangerous, where it can have serious complications involving various organs like the joints, the heart, the skin, and even the brain. So let's start by looking at epidemiology and global burden. We can see that over 39 million people are living with rheumatic heart disease globally, and also 300,000 plus deaths per year attributable to rheumatic heart disease. And also you can see that over 470,000 new rheumatic fever cases are gotten annually. And should also know that it is the number one preventable cardiac disease in young people. Looking at risk factors, we need to know that this is most commonly affecting children between 5 to 15 years. That's very important. Common in Sub-Saharan Africa, South Asia, Pacific Islands. Overcrowding, given that this is a respiratory infection, so it can spread easily. Poor sanitation, limited healthcare access. Then poverty is strongly associated. In fact, it's a disease of the poor. Then you can also see that male to female incidence is almost the same, only that for females, they have more severe mitral disease. Then we can also see that the cascade, as we're going to explain later in details, as we're looking at the pathophysiology, that we're going to start by Group A Strep pharyngitis, which will later lead to acute rheumatic fever, later progressing to chronic rheumatic heart disease, which will give you the valvular dysfunction that can later cause heart failure and its complications like stroke, atrial fibrillation, as we're going to see later. Now, pathophysiology. The hallmark here is molecular mimicry. So you need to first understand what molecular mimicry means. So, molecular mimicry simply refers to the similarity between the bacterial antigens and the human antigens. We need to know that the bacteria have some proteins, for example the M proteins, which are similar to some proteins in the human body. So that similarity between the human proteins and the bacterial protein is what we call molecular mimicry. So what happens is that when this bacteria affects or attacks the human body, it is going to be acted on by the immune system. And we know that the immune system is going to produce antibodies. So these antibodies are being formed specifically for the bacterial antigens. But since there is a similarity between the bacterial antigens and the human antigens, which we are calling molecular mimicry, these antibodies that are formed against bacterial antigens can also attack human antigens. So there is kind of cross-reaction. Now looking at this here, we can see that we're going to start by this infection, the Group A Streptococcus infection, whereby now the immune system is going to come in by producing antibodies against the antigens. But since there is a similarity between these antigens, these antibodies formed against bacterial antigens can also attack human antigens. Now, since these antigens are found in various organs of the human body, for example, the skin, the heart, the joints, and the brain, it means that when these antibodies are formed, they can also affect these organs. Now, to note here is that for the human body or the immune system to fully form antibodies against a bacterial antigen, it takes around 2 to 4 weeks. So as we're going to see later is that from the time this child is acquiring the throat infection to the time these manifestations are going to start appearing, there has to be a time range of about 2 to 4 weeks, simply because that's the time the human body is going to take to form these antibodies. So starting with the heart, we need to know that the heart wall is made up of 3 parts: the pericardium, myocardium, and endocardium. So you can have pericarditis, myocarditis, and endocarditis. Or you can also have pericarditis when all the 3 layers are affected. So for pericarditis, there's going to be fibrinous inflammation, whereby there's going to be formation of fibrinous strands between the parietal and the viscoperitoneum. So on separating these two layers, when inflammation has healed, you're going to see that it looks like bread and butter. Then for myocardium, we know that the myocardium is the muscle of the heart. And so on histology, we're going to have pathognomic granulomas called Aschoff bodies, and also still on histology, you can see what we call the anistio cells. Then for the endocardium, we know that the endocardium is what forms the valves. So the hallmark here is valvular inflammation. You're going to have valves being affected, and mitral valve is the most commonly affected valve, followed by the aortic valve, tricuspid valve, and pulmonary valve. In fact, for the endocardium, we're going to look at it later in details. Then we also have the skin. The skin can also be affected, whereby we said that the antibodies formed against bacterial antigens are going to affect the skin, because it also contains these antigens that are similar to bacterial antigens. So when the skin is affected, the hallmark here is that you're going to have some pathognomic lesions, which you call erythema magnetum, whereby you're going to have the lesions, especially on the extensor surfaces of the limbs, whereby you're going to see that this lesion, we're calling it erythema magnetum. It's going to be red around its margins. Then for the joints, there's going to be inflammation of the joints leading to severe pain. In fact, these patients are going to present with severe pain. And this type of inflammation is migratory in nature, and we call it migratory polyarthritis. So you're going to have various joints being affected, but in a migratory pattern, whereby you're going to start with some group of joints being affected, then it progresses the next group of joints, later progressing the next group of joints. So it is migratory in nature. So for the brain, there's going to be inflammation of the caudate nucleus, and we're calling it caudate nucleus cross-reactivity. And since this is part of the basal ganglia, which are responsible for movements, this patient is going to present with involuntary abnormal movements, which we are calling Sydenham's chorea. So this is very pathognomic of rheumatic fever. More about the diagnosis of this condition, as we've already seen the Jones criteria, let's look at some investigations. Now, looking at investigations, we have investigations that give us evidence of gas infection. Then you can also look at some inflammatory markers, and then cardiac investigations. Then looking at evidence of gas infection, these are investigations you're going to do that will show that there has actually been an infection with Group A Streptococcus. Now, we can do throat swab or culture sensitivity. Then you can also do what we call a rapid antigen test. As earlier said, you can also do what we call antistreptolysin O titers, and here I should know that they peak around 3 to 5 weeks, and a value of more than 200 international units per mil is significant. We can also do what we call the antidinase B. Yeah, this one, unlike the ASO titers, it stays elevated for a very long time, and values of more than 120 international units per mil is significant. Then you can also do what we call the streptozyme test, and this one detects multiple strep antibodies. So this one is just to detect that there has been antibodies formed against the strep infection. Then the inflammatory markers, as we all know, we have what we call the C-reactive protein, the ESR. You can also do what we call the full blood count, whereby you're going to see leukocytosis. You can have anemia of chronic disease. Then you can also do what you call the LDH and then troponin. Yes. Then cardiac investigations, you can do ECG, whereby you're going to have a prolonged PR interval. You can also have tachycardia, then a chest X-ray. You're going to have cardiomegaly, then a pulmonary congestion. And you can also do what we call the cardiac MRI, whereby you're going to have myocardial inflammation. And you do also the LGE assessment. So basing on what you have gotten from here, plus the Jones criteria, will help you make a clear diagnosis of this condition. Now, rheumatic heart disease, more details about valvular lesions. So, as we earlier said, that as part of the heart being affected, we have what we call the endocarditis, the endocardium being inflamed. And as we saw still that the valves here are the hallmark, so there is valvulitis. And the valves are going to be inflamed, and the most common affected valve is the mitral valve, followed by the aortic valve, then tricuspid valve, and then pulmonary valve. So for the mitral valve, we can either have mitral stenosis or mitral regurgitation. For the aortic valve, we're going to have aortic regurgitation as the most common condition. So looking at mitral stenosis, you need to know that this is the most common chronic lesion, and it is mainly due to the leaflet fusion, or what we call the chordae shortening. And these valves are going to appear as a fish mouth. So we're going to have a fish mouth orifice. So what they're trying to say here is that when inflammation happens on these valves, they have to heal. And when they are healing, there is formation of that kind of fibrous tissue. And that causes these valves kind of get stuck to each other. So when these valves kind of stuck to each other or get stuck to each other and they fuse, is going to cause reduced mobility of these valves, causing what we call the stenosis. And then the patient is going to present with symptoms like exertional dyspnea, hemoptysis, atrial fibrillation, or even emboli. What causes the emboli is simply the damage to the endothelium. Every time there is damage to the endothelium, of course you need to know that the endocardium is endothelial in nature. So every time there is damage to the endothelium, there is exposure of the subendothelial tissue, leading to clot formation. Now those clots that have been formed in this case of a rheumatic disease, initially they are sterile vegetations, but later, as we will see in infective endocarditis, is that they can actually be infected by some bacteria, and then they become what we call the infectious vegetations. But in this case, they're just going to be sterile vegetations. So that's what causes the emboli. Then the patient is going to present with signs like malar flash due to the congestion, then tapping apex, loud S1, and then opening snap. On echo, the patient is going to have an MVA of less than 1.5 centimeters, and then a Wilkins score can be used to guide the treatment. Then for mitral regurgitation, this is the most common in acute rheumatic fever. So the pathology, what causes it is that there is going to be leaflet prolapse. So due to the inflammation that is happening in these valves, they are going to weaken, and when they weaken, they are going to prolapse. They kind of become weak and then prolapse backwards. Then also you can also have what you call the annular dilation or the caudal rupture, and the patient is going to present with symptoms like dyspnea, fatigue, atrial fibrillation, but still these patients can be asymptomatic. For the signs, the patient is going to have a hyperdynamic apex. Then they can also have what we call a panisystolic murmur of mitral regurgitation. On echo, these patients are going to have an error of more than or equal to 0.4 centimeters squared. And then also, this one can guide you on surgical timing. Then aortic regurgitation is the second most common, and it is due to the cusp retraction or prolapse. So patients are going to present with late dyspnea or syncope, but still these patients can also be asymptomatic. Signs, that means on examination you're going to have water hammer pulse on auscultation. This patient can also have what you call a wide pulse pressure. Then on echo you're going to have a vena contracta of more than or equal to 6 millimeters. Management. Now earlier we saw that this condition is caused by Group A Streptococcus, and also looked at the symptoms. So in our management, we have to eradicate the cause. We also manage the symptoms. So we're going to look at the pharmacological treatment of this condition. Now to start with, we have to eradicate the gas, the Group A Streptococcus, and here we use penicillin G, what we are calling the benzathine penicillin G. and the dose here is 1.2 million units, and it is given as an intramuscular injection. So if someone is less than 27 kilograms, you're going to give 0.6 million units. So to make it more clear is that if someone is more than 27 kgs, you give 1.2, but if it's less than 27 kgs, you give 0.6 million units. Or you can also use amoxicillin. The dose is 50 milligrams per kg per day for 10 days. You can also give macrolides if these patients are penicillin allergic. Then you can also give prednisone for severe carditis or heart failure. You can also give aspirin, as I've already told you, aspirin and naproxen. And these ones are mainly for the arthritis and the fever. We say these patients present with severe pain, so they will need aspirin as a painkiller. And the doses are as follows. Then for the chorea, we say these are the involuntary movements, so they are kind of like convulsions. We're going to give haloperidol. You can also give carbamazepine, or you give valproic acid. Then we can also do what we call the supportive care. We can give supportive management, whereby you can advise the patients to take bed rest, salt restriction if they have heart failure. You can also give diuretics for pulmonary congestion. You can also give digoxin and SEIs. Then monitoring and discharge, we need to monitor ESR and CRP weekly. We need to do timely echocardiographs. We also need to do so if you discharge these patients, you need to first make sure that they are febrile and the ESR has normalized. That's when you're going to start the secondary prophylaxis. So from this, we're going to see that these patients also need prophylaxis. Now, more about prophylaxis. So we need to do secondary prophylaxis to prevent recurrency. Because every time there's a recurrency, there's an additional valve damage, and that is trouble. So the cornerstone here is benzathine, penicillin G, and it is the most effective and has shown the best adherence evidence. Although we also have other regimens like phenoxymethylpenicillin, azithromycin, and erythromycin. But looking at benzathine, penicillin G, the doses, as earlier said, if someone is more than 27 kilograms, you give 1.2 million units. And if someone is less than 27 kilograms, you give 0.6 million units. And the frequency for benzathine penicillin G, we give as IM, as we said earlier, every 4 weeks, simply because that's the duration it takes. Or we can give every 3 weeks if it is high risk. And this is the gold standard. Benzathine penicillin G is the gold standard and has the best compliancy. Then if a phenoxymethylpenicillin, the dose you can give 250 milligrams and give us as oral twice daily. Then azithromycin, you can also give 250 milligrams oral daily. Erythromycin, same dose, 250 milligrams as oral, and give twice daily. So these are the regimens we have. But now we have what we call the duration. For how long are you going to give this? So the duration you're going to give depends on the severity. So if there is no carditis, if carditis has not yet happened, you're going to give for only 5 years, all until 21 years. And the longer of the two is what you consider. For an example, if someone's like 18 years, if you'd consider to give for 5 years, you're going to give up to around 23 years. But if you consider giving up to 21 years, that means you're going to give for only 3 years. So take the first option. So you give for the 5 years. Hope that is clear. Then if there is carditis, which is mild or it has resolved, it happened and resolved, here you give for 10 years, all until 21 years. And you choose the longer of the two. So of the two options, either giving for 10 years, all until 21 years. You look and see which of the two is longer than the other, depending on the patient's age. That's what you take. Then for persistent rheumatic heart disease, you give for 10 years, all until 40 years. Still, the longer of the two is what you take. Then if it is pre or post valvular surgery, there you give for the rest of their life. So those are the options. If there is no carditis, you give for 5 years or until 21 years. If there is carditis, which is either mild or it has resolved, you give for 10 years or until 21 years. If it is persistent rheumatic heart disease, moderate to severe carditis, that's when you give for 10 years or until 40 years. Then if someone has had valvular surgery, that's when you give for the rest of the remaining life they have. So, complications. So we're going to look at the complications, prognosis, and some surgical options we have. So the complications, as we know, heart failure is most common, and it is the most common cause of death. Atrial fibrillations, yeah, it is the most common arrhythmia you're going to have, most especially with mitral stenosis. Then you also have called systemic embolism. I explained this earlier. So the emboli can also cause the stroke, ischemic stroke. You also have infective endocarditis when the arterial vegetations get infected, pulmonary hypertension due to the mitral stenosis and mitral regurgitation. And then also, if a patient is pregnant, you kind of find hard time because mitral stenosis is poorly tolerated in pregnancy. Then some of the surgical procedures we have what we call the BPMV, the percutaneous balloon mitral valvotomy. And this is a catheter-based procedure which is used to treat mitral stenosis, whereby a balloon-tipped catheter is inserted through a vein, usually the femoral vein, to the right atrium, and then crosses to the left atrium through the atrial septum, and then it goes through the narrowed mitral valve. So that is a surgical procedure for treating mitral stenosis. Then we also have what we call surgical commissurotomy, and this is done when BPMV is not possible or when it has failed. Then you can also do what we call the mitral valve repair. Here you just repair the damage, and unlike mitral replacement, the patient here will not need anticoagulation. So you can either repair the valve or replace. So for replacement, if you're replacing the valve, that means you're going to put a mechanical valve, and you'll have sentenced this patient to lifelong anticoagulation. So it can either be mechanical or biological. Then prognosis depends on the severity. For example, the carditis severity, the more severe the carditis, the worse the prognosis. Then also depends on the recurrences. As we said earlier, that every time there's a recurrency, there is more damage to the valves. Then prophylaxis adherence, as we said, we give prophylaxis, the secondary prophylaxis. So depending on how adherent the patient is, if they are more adherent, less or good prognosis. Then also access to surgery, and surgery reduces mortality. Now to summarize, these are the key messages you need to note about rheumatic fever and rheumatic heart disease. Number one is that acute rheumatic fever is entirely preventable. We've seen this already, that you can either prevent the infection from happening, or you can actually treat it aggressively. In fact, adequate treatment of the gastric pharyngitis within 9 days prevents the first episode. Then second, carditis is the only manifestation causing permanent damage. Yeah, as we saw earlier, that we have different pathologies to the skin, to the joints, the brain, and also the heart. You need to know that the rest of the pathologies, like for the skin and the brain and the joints, they can easily resolve when the fever has been treated. But for the heart, especially the endocarditis, it can actually give you permanent pathologies. In fact, when those valves are healing, they will remain fibrosed forever, and that means you're going to have it chronically for a very long time. And then number three is that secondary prophylaxis with benzathine penicillin G is the cornerstone. We've seen this already, that after this patient unfortunately has gotten this condition, you can prevent a recurrence by doing secondary prophylaxis, and that is very important. Then point number 4 is that rheumatic heart disease is the leading cause of preventable cardiovascular disease. It is preventable. This condition is preventable. So you need to know that this is the leading cause of preventable cardiovascular disease in young people. As we said earlier, that the age range here is 5 to 15 years. So that is clear. Then diagnosis, we use the Jones criteria. Yes, so you must have a preceding gas infection evidence and also use Jones criteria plus some laboratory investigations. And then lastly, surgical repair or replacement should be offered when indicated. Still, we know why. You either repair or replace. And we are saying that repair is better simply because this patient will not be subjected to anticoagulation and also has few side effects as compared to replacement. So thank you guys for keeping in. Don't forget to subscribe, like, comment, share. And if you have any queries or any questions, drop them down in the comment section. I'm sure you're going to be attended to.